Good afternoon, everyone. CurePSP's mission is to provide education and support for patients, caregivers, families, and healthcare professionals affected by progressive supranuclear palsy, corticobasal degeneration, multiple system atrophy, and related brain diseases while funding research towards a cure and prevention. Webinars are made possible by the generosity of donors and other supporters. My name is Bruce Gianelli, and I am the Director of Communications and Marketing at CurePSP. The topic of our webinar today is physical therapy for PSP, CBD, and MSA. Questions for our speaker will be accepted at the end of the presentation. At that time, a chat box will appear at the bottom of your screen, where you will be able to type and submit any questions you may have. We will field as many questions as time allows. At this time, it is my pleasure to introduce our speaker, Maria Waldy-Douglas. Maria provides evidence-based physical therapy to persons with Parkinson's disease and related movement disorders as part of a holistic interdisciplinary team at Struthers Parkinson Center. She is a strong proponent of exercise for brain change and is a Parkinson's wellness recovery trained technician. Maria is also certified in LSVT BIG treatment for persons with PD. She is a yoga instructor and teaches class at Struthers Parkinson Center on a weekly basis, while also incorporating elements of yoga in her PT practice. Maria has been a part of the faculty of the National Parkinson Foundation Allied Team Training for Parkinson's and is a member of the American Physical Therapy Association. Maria?
Thank you so much, Bruce, and I'm just delighted to see all the participants on the screen here today. I think it's just wonderful that there are so many people interested in learning about treatment for these difficult movement disorders. In my practice here at Struthers Parkinson Center over the years, it's often been that a person has been misdiagnosed with Parkinson's disease, perhaps for many years, and then come to find out that they have some atypical movement disorder such as PSP or CBD or MSA. Or at other times, somebody comes to me with a diagnosis of Parkinson's, but I've learned to recognize the cardinal features of these other atypical syndromes and may, have to point them in the direction of a movement disorder specialist. Can be a very devastating diagnosis for people, and most people haven't heard of these disorders or what the letters stand for in the disorder. And if they get on the internet, it can be even more disturbing to family members to look at some of the stuff that's out there. It's pretty negative. It's pretty easy for people to lose hope when they see the life expectancy and they see the consequences of some of the symptoms of these disorders. And to make matters worse, sometimes doctors may tell the patient, well, there's nothing you can do, simply because doctors can't necessarily prescribe medication for these disorders. However, that is not the case for us rehab professionals, especially in physical therapy. Indeed, we play an even larger role than the physician in some cases in the lives of these folks who are dealing with some very difficult issues. So I'm hoping through some of my review of the literature, which there isn't a ton of information about physical therapy in these specific disorders, and just from my years of practical experience in working with these folks, hopefully you can glean some new treatment ideas and really have something different to do when you walk into the clinic on the next day that you work and you see one of these folks. So I'd like to just jump right in to the slides. We're going to specifically talk about treatment today, since an hour time frame doesn't really allow for us to talk about all the assessment tools and so on and so forth. Hopefully you are well versed with some of the tools out there for assessing gait and balance and those types of things already as you work with neurological patients of various diagnoses. So we're going to jump right into treatment today. And we're going to start with PSP, progressive supranuclear palsy. So I think as we are looking at these folks and doing our assessments, it's important to look at the special features that make this syndrome unique and look at the impairment level as to how they affect the function of the patient. As we do with all of our therapy patients, we want to look at the impairments contributing to the functional limitations. So I'm going to address some of the key impairments that we do see in our folks with PSP, starting with axial rigidity, which just simply means affecting the spine. We know that people with PSP have a greater degree of rigidity in through the spine, and this very much inhibits their movements and bed mobility in many ways. So in order to address it, really rotation and counter rotation between the neck and trunk should be incorporated into treatment and into home exercise program. Doing some supine twists as you would do in yoga, maybe with some counter rotation of the neck, working on side-lying upper body rotation, and even doing things in a seated position. Simulated kayaking or dowel movements are often things that can be helpful. On the next slide, you'll see a picture of someone doing a spinal twist, and obviously if the range of motion isn't that great, it can be modified, or if there's back conditions where it's contraindicated. So there's many rotation exercises done in various positions that I think would be some key exercises to remember for these folks. As we know, one of the things that really stands out about PSP is that vertical gaze palsy that's so prevalent. In the early stages of the illness, it may not be as pronounced, but as the disease progresses, especially that upward or downward gaze can be very restricted. And obviously that has some implications when you're working on mobility and scanning the environment and so on and so forth. So in the early stages, it may be beneficial to work on some eye movement exercise and do some visual awareness training with these folks. And there was an article that's cited there that took a look at that and found that that was helpful. Of course, in the later stages of PSP, this may be very frustrating or difficult, and it may not be something that would be the highest priority. But looking at vertical and horizontal visual pursuit, tracking between targets, even setting up kind of a finding exercise to scan the eyes without moving the head, or move the eyes and the head together to find various objects, especially in the periphery and down on the floor in the environment, and then maybe even perhaps adding some balance challenges to those exercises if safety allows. So I just have some sample ideas. I did have some video that I wanted to include in this presentation. We had an awesome patient that volunteered and was doing some of these exercises. Unfortunately, the technology doesn't allow us to show video, so you're going to have to look at the still pictures. But you know, just as you would with vestibular patients and doing some of these same types of exercise, working on just moving with the eyes and then the eyes and head combined, looking in various planes. And then you might progress to standing and doing it, or standing on a piece of foam and doing it, and just adding the balance challenge depending on the level of the patient. And then as the disease progresses, you may have to focus more on some compensatory techniques. If a person isn't able to scan and have that saccades, that normal saccades and pursuit with their eyes, they may have to compensate by literally flexing their neck to scan the environment. And I know as PTs, we're forever telling people, lift up your head, stand tall, look straight ahead, don't look at the floor. But in this case, they may need to do this as a compensatory strategy because they're unable to move their eyes independent of their head, and they may have very limited oculomotor function. And so this is one case where you sort of have to give the patient permission to be able to be looking down. It's also helpful to address the environment and mark the edges of furniture, something that could be bumped, or even the edges of a walker with bright colored tape, so you don't have a tripping incident. Many of these folks are very sensitive to bright lights, and I know in our PT gym area we're fortunate to have some very nice windows, but often if there's folks that are very sensitive, I have to pull the blinds, maybe even dim the lights, And some people with PSP find it very helpful to wear those kind of glasses that surround the entire eye, kind of like after you have cataract surgery. And they even may need to wear those indoors at times. And that helps them so they're not dealing with that constant glare. Other considerations to think about is if you have this sort of axial rigidity that's coupled with the lack of downward gaze, you often get sort of a backward trunk lean, which is very different than the person with Parkinson's disease who often has that forward stoop. And so if they've got that backward trunk lean, that's going to affect where their center of mass is in relation to their base of support. It might interfere with transfer safety because they have that backward lean, and it may result in that backward balance loss. They are the folks that are crashing into chairs when they go to sit down. So really, really working on that hip hinge, trunk flexion, and practicing multiple repetitions of sit to stand as well as stand to sit, and really working on that sort of nose over toes and giving them that kinesthetic feel of what that should feel like, and training anyone in their environment to give them cues for that. In some cases, even putting a wedge in the shoe to shift their weight a little bit further forward, if they're really somebody that tips backward a lot, is a compensatory treatment that could be tried as well. So here's just a picture of practicing that hip hinge forward. Postural instability is present very early on in PSP, which is quite different from idiopathic Parkinson's disease, where it occurs much later or to a lesser amount in the earlier stages of the disease. These are folks that are falling often and frequently very early on. That's a huge red flag if you have a patient that may have come to you with a Parkinson's diagnosis, but their balance deficit seems out of proportion to the rest of their symptoms. So these folks are at significant risk for falls, and they really need some aggressive fall prevention strategies and education and training, as well as exercise to help with balance. So, doing balance treatment, especially if you can catch these folks early enough, is very good. Working on weight shift strategies, working on core strength, gluteals, abdominals, gluteus medius, those kinds of things. And then teaching folks to assume that Tai Chi stance, I call it, or the bow and arrow stance, where one foot is in front of the other and there's a wide space of support for stability, to prevent that backward balance loss that can often be prevalent. So I just have a picture of a gentleman standing in his bow and arrow stance, and he's doing Tai Chi actually, so he's got his arms extended. But just to really, again, get that kinesthetic awareness of where the feet are and where they should be if they're standing at the bathroom sink brushing their teeth, or they're standing in line at the grocery store, to really think about how their stance is to be the most stable to prevent falls. Sidestepping technique rather than backing up, training folks that make your first step a sidestep if you're moving away from the kitchen counter, rather than taking a backward step, which could often lead to a backward fall. And then literally having them do multiple repetitions of this type of a move, so they really have practiced this a lot to get it into their kinesthetic awareness. Clock turn, teaching folks how to do that sort of gradual quarter turn technique, as though they're standing at 12 o'clock. If they need to go to the right, then they're deliberately moving their feet to 3, or if they're moving to the left, they're going to 9, or if they're doing a 180, they're going around to avoid that quick pivot when sometimes the feet get tangled up and disaster ensues. So just really teaching folks some safe ways of turning, because we know that turning often triggers a fall. One of the key signs, and I worked with PSP for so long before I knew there was an actual clinical term for this. You might have had your own name for it, but it's the typical rocket sign, is when a person literally rockets up out of a chair very impulsively at times in an unsafe manner. And those of you that have worked with these kinds of folks know exactly what I'm talking about here. It's often kind of a really abrupt movement. They may not have awareness of what their stance and their base of support is like before they get up. They may have some cognitive impairment and judgment and reasoning deficits as well that contribute to this, and also just that poor body awareness, position sense. These folks really need that care partner close at hand, because in some cases these folks just aren't going to have the wherewithal to self-monitor and self-manage. And so that needs to be a message that gets across loud and clear to the care partner that, you know what, this person really needs somebody with them. They need someone in their environment, or they need some sort of an alarm system, because you're going to tell them to stay in the chair or to call for help, but they're not always going to remember to do that. So I think that's, again, where really the family or caregivers have to become involved, because this is a big red flag for falls. As far as assistive devices go, sometimes conventional walkers aren't heavy duty enough to really be of value for folks, especially as they progress. Heavier duty walkers tend to provide the most stability, especially if it's somebody that has that backward trunk lean and that kind of a gaze issue where they, their head is kind of tipped back. So you might want to consider, if they have an existing walker, to maybe add some weight to it. I had a patient with PSP once whose husband came up with a wonderful solution that I've used many, many times since. He just took some copy paper, 1 or 2 packages, to the basket of the walker. It was evenly distributed weight. She could still use the basket because she could stack stuff on top of it, but it's about 5 pounds of weight per paper package, and that gave that walker enough stability so it wasn't constantly getting away from her. A specific type of specialty walker that I've often found useful in PSP is called a U-step walker. It's a unique walker because it has a reverse handbrake system on it, so it is locked in place unless you squeeze the handles of the walker to move it. And it has a resistance control feature on the wheels to literally slow it down and increase the resistance or drag on the walker. So some of you may be familiar with it, but here's the website reference, and this is what the walker looks like. It has a very distinctive U-shaped base. It turns very easily. The difference in using this and a 4-wheeled walker can often be quite dramatic. I just had a patient who had been using this 4-wheeled walker, and it just wasn't working for her anymore, and it was to the point where her husband didn't dare take his hands off her for a second because that walker was constantly getting away from her, so he had to guide the walker. We tried this U-step, and it worked so much better for her for a couple of reasons. That lateral stability and turning stability was much better with this walker, and she had one hand that had a lot of weakness in it, and it was just very hard for her to do even braking on a 4-wheeled walker. But on the U-step, one works independent of the other, so you can just squeeze one handbrake. You don't have to squeeze both to make the walker go. And then it's very easy to brake the walker because all you have to do is release the brake. So for an individual like that, this was really a good solution for her. Unfortunately, these folks have collected some assistive devices along the way, which Medicare may have reimbursed for, and it's sometimes difficult to get reimbursement for these walkers. This U-step is billed with a different billing code than a standard walker, and sometimes using a letter of medical necessity as you submit the walker prescription can get it to go through Medicare, but there's no guarantee, and these walkers are a bit more spendy at about $600. So you want to make sure that it's really a good fit, and it can be folded up, but it is heavy for the care partner to lift. It's about 20 pounds, but they have made some new design features on this walker to make it more user-friendly than it has been in the past. So definitely check this out as an option. Functional training is so important. This same patient that I referenced earlier, her husband really wanted to be taught, how do I help her? I mean, it's great, you've given me all these exercises, that's wonderful, but what do I do? How do I get her to pivot in front of the toilet and sit down safely without crashing? So really getting those care providers involved in the treatment and really teaching them some of the key strategies to help with bed mobility, use a transfer belt, to show, them how to protect the person's skin integrity by having them do, helping them manually do a weight shift if they're sitting for long periods of time, all of those kinds of things. So including them, because these folks are difficult to transfer and move, and the care partner may not be used to doing these types of tasks, and they may be elderly and be at risk for injury. So this can be very invaluable. And this particular husband of this woman was such a pro at transferring her and had so much patience. I wish you could see how he did it. He was really a kind of a superstar in my book. I think the other real role of us as PTs is to educate when supervision is needed as the disease progresses. And sometimes it has to be a very frank discussion. You can't be leaving this person alone for any length of time. They're very impulsive. They're not going to listen to stay in the chair. And assessing that care partner for their physical abilities. They may have a rotator cuff tear, a herniated disc or something. They may not be able to provide the amount of assistance that's needed. There may be need for respite, support services, adult day programs, in-home care, and that's where a team approach is really so invaluable, getting the other folks on the team involved, the social worker, that sort of thing, to really give them that support that they may need physically and emotionally. And, there's that difficult conversation that needs to come about. Maybe it's time to look into a wheelchair and things like that. And there's a lot of different equipment needs that will come up in the home. And sometimes it progresses very rapidly. And, talking about electric lift chairs or wheelchair seating, and certainly collaboration with your team members, OT and speech, because these folks develop dysphagia and swallowing and are at high risk for aspiration. So positioning when eating and drinking is very important, and all of those other things. So really, taking that team approach whenever possible is going to serve your patient well. So now we're going to move on to MSA, multiple system atrophy. And these folks really have the autonomic nervous system dysfunction that are really going to interfere with their ability to perform ADLs and function in the community. Sometimes the orthostatic hypotension can be quite dramatic, and people are just bottoming out with their blood pressure. They're passing out on a regular basis or feeling quite lightheaded and faint. Clinically, orthostatic hypotension is defined by a drop in the systolic of over 20 after 1 minute of standing, and the patient is symptomatic. They're complaining of dizziness, feeling lightheaded. Some people can get quite a drop and not really be that symptomatic, surprisingly, but others very much have issues. So you're getting out that blood pressure cuff during your treatment session, and you're monitoring that sitting and standing blood pressure, especially if they've described having episodes of passing out or falling, and it sounds like the fall wasn't a balance loss, but it was more of a blood pressure drop. And then being in close communication with the doctor about that if there's a trend that there is a low blood pressure upon standing, because there's often medications that can be prescribed that can help that, but also those medications do have side effects. But it's important for you to at least notify the physician of that. And I think there's a role in just training the patient some things that they can do on a practical basis to help to manage this issue. Training for slow position changes, moving slowly, not rocketing up out of a chair, and just doing some leg kicks and ankle pumps after sitting to get that venous return and get that blood flowing up back to the heart again. Maybe elevating the feet if they're going to be sitting for long periods of time. Avoiding static standing is a big one, not just standing for long periods of time. And if they must stand for a reason, to teach them just side-to-side weight shift, contracting their quads to, again, increase that blood flow so the blood isn't pooling in the lower extremities. Making sure they have adequate hydration. A lot of these folks are not drinking enough because they have a hard time getting to the bathroom in time, or they, just getting the pants down and getting on and off the toilet can be difficult. So they may limit their water intake, which is absolutely the wrong thing to do if you've already have orthostatic hypotension. So just having some good drinking habits. Sometimes the doctor will prescribe TED hose, which of course nobody likes to wear, and they're very hard to get on and off. Elevating the head of the bed is another strategy in a wedge. If that's been recommended, they may need some training in how do I get up high enough in the bed and prevent me from sliding down, and working on bed mobility. And also just teaching about avoiding that breath holding with exertion, so they're not doing a Valsalva maneuver, which of course can cause the blood pressure to drop as well. So just some good training and education. Along with the wonderful problem of that autonomic dysfunction comes bladder issues and incontinence. And that urgency and frequency can often lead to increased fall risk as a person is rushing to try to get to the bathroom. So working with the OT on this as well can be very helpful. Talking about maybe something that could be used at the bedside, such as a commode or a non-spill urinal. And then thinking about appropriate undergarments so they're not racing to get to the toilet, especially at night. Parking an assistive device right next to the bed so they would have that to use. Having some equipment in place, especially in the toilet area with rails and grab bars and so on and so forth. And making sure there's adequate light to get to the bathroom. Often these little light bulbs aren't bright enough to really illuminate a safe walkway to the bathroom. There are walker flashlights that can clamp onto the walker, or a motion activated light, and there's always the clapper. And so you can get creative and problem solving with the patient on some things that they could do to make sure they're safe and getting up and getting to that bathroom in time. As with Parkinson's, that forward head or anticollis is often a more prevalent feature in MSA. And so one thing to address in the treatment specifically is working on that axial extension, that extension of the cervical spine, working on chin tucks in various positions, using some visual feedback of mirrors and other things, and maybe having them use some visual targets in their environment. Some patients have even gotten as far as to put little post-it notes or little reminders for their posture. I have saw a very creative woman with Parkinson's that had a very neat idea to remind herself of good posture. She developed some posture stations within her home. So every time she passed by a certain spot where her kitchen counters came to a V, she stood and pressed against the counter and brought herself up tall. Every time she walked through her bathroom door, she put her hand on either side of the door jamb and just did a slight pec stretch and tried to extend her spine straight up. And so she just had some visual reminders within her apartment on a regular basis to get her thinking about posture, because often this is an afterthought for people, or they're not even aware that their posture is starting to deteriorate. So starting first in the supine position with gravity assisting them on a folded towel or blanket so their head is in a neutral position, and doing a chin tuck in supine is often the easiest way to teach a chin tuck, because sometimes the motion's very limited. It's hard to do it initially in standing or sitting. And then progressing to that seated chin tuck eventually is helpful. So including that, and as well as other postural exercises in their exercise program. The gait pattern in someone with MSA tends to be more Parkinson-like, with that narrow base and reduced foot clearance, shortened step, instability with turning, that multi-step turn. Sometimes these folks have some significant freezing, and some folks with MSA have more of an ataxic type gait pattern. So it can really vary, but often this puts them at risk for falls. So the big factors to focus on is step size, working on big steps with an emphasis on that heel strike, much as you would for someone with Parkinson's. Working on some safe turning strategies, making a big U-turn with a wide base of support, or those clock turns that I had mentioned earlier. I came up with a little mnemonic device that I term the 4 S's for freezing. Because often people try to force their way through a freezing episode. So when the feet get glued to the floor, the upper trunk starts to move forward, the feet stay rooted to the ground, and then they try to force a step, which often leads into sort of that runaway train festination. So encouraging and educating people and their care partners about just stopping and focusing on upright posture. So stop, stand tall, and then shift. The weight shift is key to unfreezing the feet, that lateral weight shift. In the Parkinson's world, there was a project in Europe called the Rescue Project, all about specific cueing strategies that were the most effective for people that dealt with different issues. And freezing of gait was one of those issues. And one of the most effective strategies was found to be that lateral weight shift, because what's happening in a case of freezing is often an incomplete rapid weight shift from side to side, so they're never fully unweighting one foot to be able to take a step. So working on that lateral weight shift, side to side to unlock, and then making a decision, okay, step long, and even identifying which foot is going to take a step first. Often I tell people to step with their sticky foot first. If they have one foot that tends to have more trouble than the other, to focus on the sticky foot first to initiate that step. And going through this, even when they're not having freezing, and just really working on some weight shift activities can be very helpful. So I just have a picture of that just to kind of emphasize that lateral weight shift, and sometimes even going with a wider base of support for even more stability is helpful. In early stages, if balance isn't overly compromised, treadmill could be used, or even a harness system like the light gait for consistent speed and cadence. The step estimation technique is something that I've found helpful for certain individuals, rather than focusing on their destination and kind of picking up speed with shorter and shorter steps. Have them estimate how many steps it's going to take them to get from point A to point B, and then literally count out the steps as they walk. There's something about that then entrains sort of a rhythm to their gait and gets them to take longer steps. Rhythmic cadence cues, much as they work for folks with Parkinson's, based on the work of Dr. Michael Tout in Boulder, can be very helpful to establish a good gait cadence. Having them count out loud, use music that has a definite beat, or using a metronome can often be very helpful for these folks to kind of help establish that rhythmicity of gait. Gait is intrinsically rhythmic, and so the brain can entrain itself to the rhythm of the music, which kind of re-establishes stability and rhythmicity of the gait. I have the good fortune to work with a music therapist, and we collaborate all the time with some of these folks that have a lot of freezing or difficulty walking, and it really works well for folks, even folks with dementia that may not understand these 4 S's and how to unfreeze, but just using music or rhythm or clapping or counting can entrain their gait pattern. For the folks that have more incoordination and ataxia, in terms of exercise training, sometimes working on some stepping exercises using targets on the floor. We're kind of hula hoop crazy around here at Struthers, so we have like the child-size hula hoops, and we may make a target and step into this hoop and then out of this hoop, or do different things like that, so it doesn't have to be anything really high-tech. If you're familiar with the 4-square step test, there is an actual device you can use, or you can use 4 canes or dowels, but we actually have a little device that came with our Center of Evidence center that has a bunch of different balance equipment on it, and it just folds out 4 different ways. And I have people practice doing exercises, walking from one square to the next, or walking and doing a 90-degree turn to the next square, or things like that. Or you can just take some masking tape or painter's tape even on the floor and have them do that. Sidestepping and retro walking are often effective training tools as well. And if you have a harness system, you can also try that on the treadmill as well. So here's a picture of the 4-square stepping. This is actually a test, but you can also use it for treatment. And it's for people that have reduced foot clearance. It's a really good tool to use. The other thing that we use a lot of are the foam swimming pool noodles. Those work great because there's nothing really dangerous about stubbing your toe on a noodle made of foam. So just working on stepping over the noodles or making a square of the noodles, or sometimes having a sequence where they have to step over several noodles placed horizontally on the floor. So you can have all kinds of fun with different toys in your treatment. Balance training is often an integral part of treating these folks as well. So working on the things you would typically work on with balance training, varying the base of support, eyes closed, compliant surfaces or obstacles, depending on what stage folks are at, and just working on some simple ankle strategy weight shifts as I have in the pictures, with the feet staggered or the feet just wide apart, and then progressing from there to a compliant surface or with the eyes closed, always keeping safety parameters in place to prevent falls. Again, as far as assistive devices go, the 4-wheeled walkers with the handbrakes with added weight if necessary can be effective in some cases. And again, that U-step walker is a viable option for folks for which the 4-wheeled walker is getting away from them too quickly. There is an add-on feature to the U-step that can be helpful if a person has significant freezing that acts as a visual cue. It's a laser that projects a line to the floor, and you can adjust where the trajectory of the light is depending on where their feet are in relation to the walker. And it's just a red laser line on the floor. And that can provide a target to step over if a person has significant freezing. Now, this may not work for everybody, and some people get sort of what I call cue fatigue. So a visual cue like this works well for a period of time, and then they sort of become immune to it. It is somewhat of an expensive add-on feature, so I don't advocate it for everybody, but for the right person, it can really be effective. The other thing that I had a patient rig up on his walker, which I thought was a genius, is you can go to Home Depot or Menards and get a laser level, like you would need if you used a level to hang a picture. And he just rigged it up to his walker, and it, duct taped it or whatever, and it projected that laser line to the floor. So that's kind of the poor man's alternative to the laser on the U-step walker. As MSA progresses, and it often can progress rather quickly, home safety and fall prevention really are priority one. And in some cases, a wheelchair may be the safest option for the individual, with a reclining seat if a person has a significant forward head and so forth, and really working on training the care partner in safe transfer skills and safe ways of assisting a person out of a freezing episode, and almost dancing with them to get them to weight shift, and where to put their hands and not pulling on the patient, and just things like that, to really it's a kind of a quick journey sometimes in this MSA person, and so things can progress rather quickly from 1 month to the next. So they may need multiple episodes, just short episodes of care to train as different symptoms emerge. Here's a picture of the laser feature of the U-step walker. You can see that projected red line at the floor. And this is not often helpful in PSP if a person doesn't have that downward gaze. They can't move their eyes very well. This may not work as well for a person with PSP, because people with PSP can also have freezing of gait. The last disorder I'm going to be talking about today is Corticobasal Degeneration, CBD. This is often a very difficult population to work with. One of the key features of this is a marked asymmetry of symptoms. A person may have a very much affected upper extremity or lower extremity, or sometimes both. There's apraxia, motor planning difficulties significantly on that side. And there is gait and balance implications. And so these folks, again, are at a very high risk for a fall. I had a woman recently that came to me with a different diagnosis, but it was very clear to me that this is probably what she was dealing with. She had such apraxia in her left leg, she could not move it voluntarily without manually assisting it with her other hand. She had significant rigidity in the leg, but it was also just very difficult to just bend it up for bed mobility, position it correctly for transfers. And her gait pattern, we could not get her to have any knee flexion during swing phase of gait. She was hip hiking on the other side. She was falling so often. She was wearing a helmet. She had a heavy duty walker. We tried the U-step with her. It wasn't as helpful. She just had a weighted down four-wheeled walker, and that was probably about as good as it got. And so I think we had to take the focus off making her gait look pretty because it just was not going to happen. We tried the treadmill, we tried the harness system. And so I think then getting the focus off, okay, this gait pattern doesn't look good, but what can we do to improve safety and prevent falls? Sometimes as therapists, that's a difficult mindset because we want to fix people's gait. We all do. And, we're mentally always trying to think of what we can do, but in this case, I think it was better to just focus on what can we do for safety. And she was really, really motivated to keep walking, was, knowing that wheelchair was on the horizon, but she was very committed to staying active. So, unfortunately, there's not a lot of evidence in the literature. There's not a lot published about treatment of CBD in physical therapy. Often the focus of treatment is a little bit of a shift to compensatory strategies rather than restorative treatment, training of the care partner, and prevention. Prevention of contractures in some cases or skin breakdown, and fall prevention. And in some cases, talking about wearing knee pads if you fall a lot forward, or wearing hip protectors, or wearing helmet if you are really committed to walking. Because of this asymmetry, using a mirror in treatment can help sometimes, and working on some targeted coordination exercises, reaching towards a target or stepping towards a target with the lower extremity. This lady, we did a lot with a beach ball because it was lightweight enough for her to be able to use. We did a lot with hitting a mylar balloon back and forth because it moved slower. That was better than a conventional balloon. Just working a lot on getting her to open her hand, getting her to move her foot, getting some knee flexion. So sometimes you have to really kind of do some trial and error. Alien limb phenomenon. This is something it's not something that occurs with regularity, but you do see this in these folks with CBD. The limb really appears to move on its own. The patient is not trying to move it. It almost appears as though it was dyskinetic, which is a side effect of Parkinson's meds, but these folks typically are not on Parkinson's meds, and the limb is just moving of its own volition. Sometimes patients almost have a neglect of that side, and they may feel like that doesn't even belong to me. There also may be some dystonia or fixed posturing of the limb, and elbow flexion, wrist flexion of the upper extremity, hand is fisted. The woman I was talking about earlier had a real strong inversion of her lower extremity with the foot turning in very strongly. So, that has implications for contracture and obviously some gait and balance deficits. So this may be somebody that may need some sort of bracing or splinting. So consulting with an orthotist or prosthetist or an occupational therapist may be in order. And in some cases, folks are not able to effectively use a walker with both hands. And so there is a type of walker, and I haven't used this very often, but I have used it. So the Evolution brand four-wheeled walker has some different add-on features. And they have an arm trough, which you can kind of see in this picture, which is like a platform walker, but you have brakes upright, vertical. and you can see the brake is in front of the handle, so they can squeeze it to stop the walker. And you can just do it on one side if need be. So they're balanced and they're not tipping the walker over. So that is something just to keep in mind. And again, it's probably not the fix for everybody, but if somebody's determined to stay walking, it may be an option. Again, the gait and balance changes are similar to the changes that you might see with Parkinson's, although that apraxia is kind of an added thing that you see in a greater degree than in someone with Parkinson's disease. There may be some motor planning issues that are more significant. And in some cases, the person may be only recommended to walk with one-on-one assist and a transfer belt. And, may have to have that difficult conversation of you're no longer safe to walk alone due to your high risk of falls. And in some cases, the wheelchair may be that option. A manual wheelchair is going to be hard for someone that has an apraxic unilateral kind of a condition in some cases, so power wheelchairs maybe need to be considered as well. With the particular patient I was mentioning with the apraxic leg, we did do some rhythmic auditory stimulation along with a music therapist to some degree of success. It didn't necessarily improve the quality of, her gait pattern was still very awkward and difficult in it, but her cadence improved quite a bit. And so that to me shows a little bit of reduction in fall risk because obviously that gait speed is correlated with fall risk. So to explain what rhythmic auditory stimulation is, it is a neurologic music therapy technique that uses rhythm and music to facilitate activities that are intrinsically rhythmic like gait. You can use a metronome, you can use music at a set BPM. And you can also use sort of a mnemonic device like push and step and push and step. So it can be something very simple like the sound of a voice or sound of clapping or counting, or it can be literally, you can look on different apps online for the beats per minute of various music, and you have to kind of experiment with what BPM is going to give you the best quality of gait and the safest gait. And so with this woman, it actually was 50 beats a minute, which is quite slow. But we do have in the music therapy area some specific rhythmic auditory stimulation music that was developed by Dr. Tout at Poudre State in Boulder, Colorado. And so it's a whole CD of music at 50 beats a minute. And she had the old Walkman, Discman still. And so she would literally walk in the halls of her apartment with the headphones on, listening to this music. And I think, we did have some success with it, and it was a viable option. That's something to consider. We're not all music therapists, but I think we can make use of just simple things that may be helpful using music or using clapping or counting. And there's very many electronic portable metronomes that you can just hold in your hand or clip on your ear that just simply give a beat, and you can adjust the parameters of that. Coordination exercise, again, I touched on that before, and working on some reciprocal arm activities is often helpful. I've got some pictures of some different ideas of exercises from 4-point on the mat to kicking towards a target. I don't know why there's a bowling pin in this picture, but that was just the picture I found. I tend to use like a visual, the hula hoop on the floor or the beach ball or something like that, reaching towards various targets placed on a wall. Those are all some treatment ideas. So that comes to the end of the presentation and to this research list that was prepared by Heather Cianci, who is on the board of CurePSP and a wonderful physical therapist. So there's different articles depending on the condition. So feel free to make use of that. And then I did include my contact information if you ever would want to send me an email with a question or something, or if we come to the end of our time and we run out of time. So please feel free to contact me. And now we're going to go ahead and take questions from the audience.
Maria, thank you for that wonderful presentation. We're going going to open it up now to questions. So your screen will change a little bit. You'll see a box at the bottom of your screen where you'll be able to type in questions. So go ahead and do that now, and we will field as many questions as time allows. So go ahead and type your questions in now, and we will try and answer them. To answer the question about whether or not this presentation will be available later, we are recording this webinar, so you will be able to watch it in its entirety, and we will also, with Maria's permission, publish a copy of the slides on our website as well.
Absolutely.
For people to access at a later date.
Absolutely. So the question comes, can we print the presentation for future reference? I would absolutely support that. You could use it for your own clinical reference. Obviously, presenting the material as your own would not be a good use of it, but with proper credit, I certainly want to spread the word. My friend Beth has a question. Can the U-Step walker be ordered directly from the website, or do you have to go through a vendor? That you can go directly through the website, and I had listed the website earlier in the presentation. In-Step Mobility will basically mail out the walker in a box. There is a little bit of assembly required, but I've assembled it from a box, and if I can do it, I think most people could do it. And so you can go directly through them. You can submit your prescription through them and get a hold of it through them. And so the next question is about dementia and CBD. Have you noticed there's a dementia component with CBD patients? I would say in some cases, yes, dementia is present. In other cases, this patient that I was using as my example is not so much. She's very mentally clear. So I think that's one point that's well taken. If there is any cognitive impairment that is suspected, some sort of a cognitive screen or testing would be advisable to really determine the extent. And maybe they don't need to go through formal full battery neuropsychometric testing, which can be very exhausting and somewhat demoralizing for people. But even our speech therapists do a wonderful job and collaborate with our occupational therapists at doing some cognitive assessment and then giving very functional strategies for dealing, not just identifying the cognitive problems, but also giving strategies. Where is it possible to find PTs, locally that have this information or training? That is a very good question. I don't know that we have a database now where you could say, okay, here's where there are specialized PTs working with these atypical movement disorders. I would say your best bet would be to find a clinic such as ours that is a National Parkinson Foundation Center of Excellence, because chances are if you're treating large numbers of people with Parkinson's, you're treating people with related movement disorders. And so they're coming to say, do I have Parkinson's? And then they might find out, well, no, you don't, but you have PSP. So PTs that work in these type of facilities tend to probably see more patients with these kind of disorders. So that may be a way to start on the NPF website. I don't know through the APTA if there's any sort of special interest groups just for atypical movement disorders. That might be another venue. It'd be great maybe if we could start a database on the CurePSP website at some point. That would be a great idea.
Maria, for reference, CurePSP recommends that people use the NPF Centers of Excellence to find a physical therapist or a doctor in their area that is familiar with PSP, CBD, or MSA.
Okay, good deal. How do you handle patients with frequent falls and questionable injuries attending outpatient therapy? Yes, that is my world. That is where I work, in the outpatient world. And it's hard because sometimes a family member may not come in with the patient, or they may not give you the straight story because of dementia or because of pride or embarrassment. So I think it's really important to try at least extend the invitation to other family members or caregivers to come to treatment, or you would have to get permission from the patient before you would contact any of their caregivers yourself because of HIPAA regulations. But I think that's the best thing, is to get the family involved, and then also, if you work in a team, to get your social worker involved. I mean, we are fortunate enough to have programs that, like day programs and support groups and things like that, or respite care available. So I think, looking at the whole picture. Let's see. Are there any exercises or help for patients that are having extremely difficulty in swallowing? The patient is no longer mobile. That would be a referral to speech therapy. They know more of the specifics of the swallowing mechanism, muscles of swallowing, and have some very specific exercises. And sometimes they even do stim exercises and all kinds of different things for folks. So I would definitely say that would be out of our scope of practice and more into the speech realm. Do you have any exercises for clients with dementia, with Lewy bodies? I think, really a lot of what we talked about with some of these other disorders, such as MSA, the Lewy body stuff, is stuff that you can use these other strategies that I talked about. But with Lewy body, there is that significant component of dementia that can be so pronounced. So I tend to go with more movement patterns that are familiar to a patient rather than specific exercises. For example, okay, we're going to row a boat, or now we're going to swing a bat, or things like that. That can be helpful depending on what the impairments are. If a person is having more difficulty and apraxia, you may have to enlist the help of a care partner because the person may have difficulty monitoring their exercises. Is it useful to train those with alien limb, much like you would with neglect and CVA, or does this not respond? I can only really speak to that from personal experience. I've never seen anything published about this using mirror therapy or anything like that, so I don't know. I would think it would be a reasonable idea to try in treatment. I personally have not had much success. This woman that I had recently worked with didn't have the alien limb, but she had such apraxia, and it was just very difficult to do. We tried all sorts of things. But I think it's definitely, worth trying that. How do you determine if a patient has been misdiagnosed with PD when some of the symptoms are similar to the others? And, so I think it's really important to understand the key signs and symptoms of each of these disorders, and CurePSP does a great job on their website, and so check out some of the other things on the website. And I think sometimes, we are not in the position to make a neurological diagnosis, but we can certainly make a recommendation to say, you know what, I think maybe you need to see a movement disorder specialist, or, maybe, a second opinion might not be a bad idea. Or maybe you can have if you have a relationship with the physician, have a private conversation with the physician. And if there's expectations of the family, like this person is going to completely improve, as another question had asked, to set those realistic. We want to give some hope, but we also want to have some realism mixed in with that hope. How do you adjust blood pressures with large swings and no symptoms? Most of the patients, sorry, I can't see the whole question. So I think if the patient is not overly symptomatic, I don't know that it's something that we necessarily have to address to a big degree, as long as they're not in any danger of having passing out, fainting. It's amazing how low some people's blood pressures can go before they're symptomatic. But I would definitely still record it, document it, and report it to the physician, always. So we are communicating that to others involved in the care. You know, there's one thing I do want to address because a question did come up about this, that people as myself are LSVT big trained and certified. I am not aware, and I can correct me if I'm wrong, that there is research out there to support LSVT big training for people with these atypical movement disorders. On an anecdotal basis, that may be the case, but my kind of bent towards this is there are many impairments to address in these folks, and hypokinesia, which is the main symptom that's addressed by LSVT big, is often not the biggest problem for these folks with atypical disorders, and our time would be better spent in training in mobility and training in fall prevention and those sorts of things. In this day and age of Medicare restrictions and therapy caps, I think we have to be very, think very closely about how we're donating or directing, not donating, directing our efforts at treatment. And so I'm not saying that I don't use some of these strategies and techniques with my folks with PSP or other of these disorders, but I don't know that the full protocol is necessarily appropriate. So I think we may have covered in very speedy fashion all of the questions that I've seen.
Looks like there was one more. Do you know of any neurologically stimulating games or apps that can help a PSP patient?
Oh, such as luminosity or those kinds of things. I think some of the things that you may use in other conditions for cognitive impairment, I'm not as familiar with luminosity, so I don't exactly know what's on there, but I think especially for some visual exercises and things like that would be very helpful. I am not the world's most tech-savvy person to use that in my treatment on a regular basis, but I'm sure there may be some software that's out there, but I think incorporating some of the eye movements, finding things on a screen, things like that would be helpful. Wii games, if the person has balance, I have used the Wii bowling and some of those other things with folks, and some people, if they have access to that at home, really like to use that. Oh, we do have another question about standardized tests do you utilize? So we're talking about assessment tools, and again, we didn't have a lot of time to get into that, but for balance assessment, especially in the Parkinson's realm, the things that have evidence to support their use and good sensitivity would be the Berg Balance Scale, or in patients that are a little bit higher functioning, the Mini Best or the BEST test. Would be appropriate tools, the functional gait assessment, gait velocity testing, timed up and go, 5-time sit to stand test. Those are all tests I regularly use in the clinic to assess function and are sensitive enough to change where we can have some test and retest improvements seen.
Okay, well, it looks like we're all out of time, so I would like to thank Maria very much for taking time out of her busy schedule and volunteering to do this webinar and present this information to everyone. I'd also like to thank everyone else for attending. I hope you found the information helpful. Again, we will be recording this webinar and posting that on our website for people to view afterward, along with a copy of the slides. So be sure to hit the CurePSP website starting tomorrow or afterward. So thank you all for attending and have a great day.